Yes, hello once again. This is video 12 in the Tulip Airway series of explanatory videos. I was asked to put together a video of the top 20 questions that consultants ask. And one of the commonest is, what problem does the Tulip solve that the LMAs and iGels don't? In other words, why should you change from one to another? And the answer is basically Tulip works when everything else has already failed. Tulip is an oropharyngeal airway, so it sits in the glossopharyngeal nerve area. So it is tolerated, fully inflated in a semi-conscious patient. That allows them to breathe with intact laryngeal reflexes. That combination doesn't exist anywhere else. Second question, is this not just another supraglottic airway? Well, the answer is no, because Tulip is oropharyngeal, it's not supraglottic. So it is completely different. In this, basically, COPA was an evolution of the Goodell. The iGel is an evolution of the LMA, and it's fair to say that Tulip is a mutation because it doesn't derive from anything. It sits behind the tongue. That means it sits in the glossopharyngeal nerve distribution, which is why it can be tolerated in semi-conscious patients. If you look at some of the videos on the Tulip website, you'll see that patients swallow with it in, they pull it out, and then they cough to clear their own throats gently. This isn't gagging, it's just straightforward laryngeal reflexes in action. So, can a patient tolerate this while awake? The answer is yeah, they can. If you want to use it in sedation, I recommend a lignocaine spray, 1%, something like that. Give it 5 minutes. But the point is that it's also not only on the way in, it's also on the way out. Patients can self-extubate safely. They do that with turned reflexes, and once that happens, they can't die because their reflexes are intact, so they won't get obstructed airways. Okay, what about aspiration risk? Well, the aspiration risk is actually lower with the Tulip because mask ventilation or failed LMAs tend to use much higher pressures. Cadells and masks tend to be overventilated mostly by consultants because you have to be skillful and generate a lot of force, a lot of positive pressure to get any kind of tidal volume out of a Cadellan mask. I think if you're a consultant, you know that. And Cadell mask is quite a high pressure, high resistance system. And Tulip has the largest airway tube of any device and has a low pressure, low resistance system. So Tulip actually gives you significantly larger tidal volumes for significantly less pressure. So in the research and the clinical trials that are published in Anaesthesia, Tulip actually has lower peak pressures, higher average pressures, because half the time, 41–45% of the time, the user of the Cadell can't do anything at all. But Tulip generates higher tidal volumes, lower ventilation pressures than what you used today. Okay, when should you choose a Tulip over an LMA? Well, bottom line is you can use a Tulip instead of an iGel and LMA for everything. But specifically, and this is when the patient is semi-conscious, when iGels and LMAs can't be tolerated. So when you can't wait, when the anatomy is difficult, if it's a difficult airway, or when the airway is collapsing dynamically, in all honesty, Tulip works even better in difficult airways because of the principle, which is a tube with a cuff inflating outwards. So if it's a tight airway, it seals faster, So Tulip works really well in, non-ideal conditions. I think that's one of the most useful things about it. So is there evidence of that? Yeah, loads. We have 3 documented life-saving cases that have all been published and presented by consultants in different countries. 3 different consultants, 3 different countries, 3 different events. And that was Tulip saving somebody's life when everything else had already failed. Sounds dramatic because it is. And some of those presentations included the World Military Congress in Brisbane in September last year, 2024, and in Euro Anaesthesia this year, 2025. So what about sore throats and trauma? Well, basically Tulip is superficial. It doesn't go deep. So there's no compression or mucosal trauma. In fact, Tulip has the softest cuff of any known device. It's certainly better than repeated laryngoscopy or, LMAs or I-gels, which, quite frankly, the same size as my shoe. But tulip cuff pressures basically are the lowest known. They're supposed to be, and this is printed on every tube, 40 millimeters of mercury, 50 centimeters of water, which is the same as mucosal perfusion pressure. Therefore, technically, the blood should still be flowing. So technically, you should be able to keep a tulip in longer than any other device. And we have weaned people in intensive care after major operations for up to 12 hours on tulips, so you can do that too. Can it be used in resus? Absolutely, yes. That's what it was designed for. That's one of the strongest indications, in fact. In fact, the tougher the situation you're in, the more I recommend tulip. Okay, what about difficult airways? Exactly. That's exactly who this tulip was designed for. Basically, if the tongue collapses, you've got loss of tone. Basically, the tulip behind the tongue removes the only obstruction. And a full cuff seal, which is high volume, low pressure, prevents any leak. Okay, is it a replacement for intubation? Well, no, because basically if you need an endotracheal tube, you need an endotracheal tube. It's more before and after. You can intubate through it. It's, for all recoveries, it would be ideal because of the self extubation that's fully awake. But you can use an ENT tulip instead of intubation, e.g. no paralysis required, for things like ENT, for things like dental, nasal, oral, facial surgery, anything above this level. And then you don't have to paralyze, you don't have to intubate, and that, quite frankly, one ENT tulip, which has an adapted tube, replaces a Guedel, a mask, a laryngoscope, an ET tube, succinylmethonium, neostigmine, 2 needles, 2 syringes, McGill's forceps, throat pack. I mean, what is that? Saves you $1,000 per case? I don't know. Could this delay definitive airway management? No, it'll actually save you time. It'll probably save the patient's life, in fact, because the hypoxia will be worse than the indecision. And I just want to make this clear that basically the clinical evidence already demonstrates that tulip is likely to be that definitive airway management that you're talking about. So is it difficult to insert? No, not at all. In fact, 77% of users prefer it. Usually takes you one session. After one mannequin training session, every single trial is 100% successful. And I mean our trials, other people's trials, and that means inexperienced users, nurses, doctors, medical students, ODPs, paramedics, the secretary, in fact. So this is designed for everybody to use, including 8-year-old kids at home, on a collapsed parent. What about peds? Well, basically, to be fair, because this is a new device, I don't really want you going heavy for peds until you've learned to use it in adult. I think we all agree on that. So the current focus is adult use, but everything that an adult gets, a child will get, right? So basically, the development series is planned, not speculative. You've already got 2 sizes, so and that's between 5 and 10, and between 10 and 15, so you can get cracking. So where does it sit in the algorithm? Between the failed Guedel, e.g. with a face mask, an LMA, an I-gel, and a surgical airway. Now, as I said before, tulip has been shown to prevent cricoid thyroidotomy in at least 3 cases, and 15 is that question, and the answer is yes, it already has. Now I've got to tell you, if you don't understand that basically tulip saved 3 lives when everything else had already failed, and you don't understand that, I'm probably wasting my time. We've seen that happen 3 times, 3 different countries, 3 different consultants within the first 6 months of tulip release alone. I mean, it's got to be something going on. So, is semi-conscious tolerance dangerous? This question slightly confused me, but okay. The answer is no, it's safer. Conscious reflexes protect the airway. Forcing deep anesthesia creates risk because the airway's reflexes disappear, you lose your airway, end of that. Okay. What about oxygenation efficiency? Well, if I use the word excellent for plus 250%. I think that's fair. Basically, spontaneous breathing and airway patency is immediate, but you basically get an increase in oxygenation because Tulip, in the clinical studies that were published in Anaesthesia, provided 77% larger tidal volume, which is huge, for 19.11% less pressure, so less regurgitation risk. And because it has 10% of the dead space of a Guedel mask, and because it's directly connected to a Baines anesthetic circuit, it's delivering 100% oxygen. Now, the Guedel mask, this is a matter of some discussion, but it's supposed to be rebreathing. What's the maximum you get out of a mask? Some say 60, some say 80. Well, basically the calculations with the increase of tidal volume, with the increase of oxygen content, all of that added together, the Tulip provides 250% more oxygen if we agree that a mask provides a maximum of 60, and 150% more oxygen if we agree that a mask provides 80% oxygen. I mean, and that's in addition to 101% more CO2 elimination, so less acidosis and arrest. Okay, so here's one. Why hasn't it? This is actually becoming increasingly common. Why hasn't something like this existed before? I've got to say God knows, because I don't know. But basically the bottom line is, I don't know, we grew up in an era where it was like the airway is difficult. No, it's not. It's a Guedel mask that's difficult. A Tulip is easy. And I think this is the one thing that makes me the happiest. It's like you convert something that was impossible into something that's just easy. And so, Tulip was designed for you. And when I'm saying you could be a consultant, you could be a nurse, you could be a paramedic. I'm up for all of you. You could be an 8-year-old kid going, how do I keep my dad alive? I mean, that was me. Because another question here is that, is it suitable for pre-hospital, out of hospital, in emergency department use? And the answer is absolutely. I mean, it's immediate in effect. It's the fastest IPPV. You're going to be managed beautifully. I just say try it in a mannequin first, so when you can mess around properly to get to know it. But look, okay, here's the question that I quite often get more and more of. Why did I develop this? Well, quite frankly, people die every day, airway complications, and my dad was one of them. All right, so I turn up 20 minutes late. He's got an esophageal intubation. It's not looking good. Anyway, so basically that's why I did it. Well, actually, he taught me to resuscitate when I was 8. So I've been thinking about it since about that age, actually. How do you stop your dad dying when you're 8? And the answer is with a Tulip, actually. So, this is basically to stop your dad, snuffing it in quite the same way. I hope you find that useful.